We continue the differential diagnosis of lower genital tract infection. The second cause of lower genital tract infection is candidiasis. More than 75% of females had at least one episode of candidiasis. If you had recurrent, which is called four or more than per year. The organism is carried in the nail, gut, vagina, and in the skin. The 80% caused by Candida albicans. What is the classical presentation and what is the leading symptoms of candidiasis? Itching and soreness of the vagina and vulva. The leading symptoms is mainly the itching with the presence of cheesy like white discharge which may smell yeasty. Vulval edema, and excoriation are common findings, which is called vulvovaginitis. The pH of vagina is normal. Microscopic exam reveal the presence of pseudohyphae and mycelia. Culture is not routinely recommended except in those with failed empiric treatment. What are the risk factors for candidiasis? The immune suppression with HIV, diabetes, and vaginal douching. Pregnancy by itself is considered as a risk factor for candidiasis, and recurrent attacks of candidiasis may occur in pregnancy. Female with taking oral contraceptive and due to increase the effect of estrogen. How can we classify candidiasis? Candidiasis can be classified into complicated and uncomplicated. The uncomplicated usually sporadic, mild to moderate, caused by albicans and in non-immune suppressed. The complicated usually recurrent 4 or more per year, severe due to non-albicans species and occur in immune suppressed. Treatment Local treatment is better than systemic to decrease the side effect of the drugs. Different doses and durations are available. Intravaginal agents such as clotrimazole, 5 gram vaginally for 7 to 14 days, or tablet, miconazole preparation, nystatin, oral agents such as fluconazole, 150 milligram orally. The treatment of recurrent is usually with once or twice per month for 6 months. The third cause of lower genital tract discharge is Trichomonas vaginalis. It is an STD and can be asymptomatic for several months. In men, it is often asymptomatic but may be present as non-gonococcal urethritis. 70% of male are asymptomatic. In female, the leading symptoms and the presenting complaint of the patient is mainly severe vulvovaginitis, which is the leading symptoms. It is more present with itching and soreness, with a purulent and sometimes offensive vaginal discharge. In many cases, bacterial vaginosis develop as well. The presence of trichomonas is a marker of high sexual behavior, and co-infection with other STD should be looked for, especially gonorrhea. The parasite has prediction for squamous epithelium. The examination on vaginal exam, we can see a yellow-green discharge with inflammation and sometimes extended outside to the vulva and adjacent skin. The pathognomonic and the diagnostic feature is the presence, what we call it, the strawberry-like cervix, which is due to subepithelial hemorrhage. It is a pathognomonic of gonorrhea, of Trichomonas vaginalis. The diagnosis, the incubation period required 3 days to 4 weeks. The vagina, urethra, cervix, or urinary bladder can be infected. No symptoms may be present up to 50% of female, and such colonization may persist for months or years. In those with compliant, due to discharge and signs of vulvovaginitis, on speculum exam, you can see the strawberry-like cervix, microscopic identification of the protozoa on the slide by the presence of the characteristic parasite, which is an anteriorly flagellated motile anaerobic protozoa. The sensitivity of this slide is 60%. Vaginal pH usually rise. The other tests, such as nucleic acid amplification test, which is more sensitive and specific. And once we suspect Trichomonas vaginalis, we should screen for other STD in the female and in her partner. Treatments with metronidazole single 1 gram oral dose or 5 milligram twice daily for 7 days, or tinidazole 2 gram orally as a single dose, treatment of the partner. The other cause of discharge of the genital tract infection is the upper genital tract infection. The term used to describe genital tract infection due to endometritis, parametritis, salpingitis, or oophorytis. These infections usually spread from the cervix and the vagina, so, what we call it an ascending infection, or could be through lymphatics, bowel, or bloodborne. 80% of the organism are STD, either GC or chlamydia, and secondary invaders such as bacterial vaginosis, such as bacteroids and mycoplasma, coexist. PID is an important condition because it results in tubal obstruction and tubal damage with infertility and ectopic pregnancy with chronic pelvic pain. The first causative organism is Chlamydia trachomatis. It is the commonest bacterial STD. It is the commonest bacterial STD in the developed country, especially in female less than 25 years. Many infections are asymptomatic, 50% in male and 80% of female. Once it is asymptomatic, we usually deals with its sequelae, which is the chronic pelvic pain, PI, infertility, and ectopic pregnancy. In male, it is most common cause of non-gonococcal urethritis. It causes cervicitis and PID. The genital strains can colonize the throat and cause conjunctivitis. There are several strains of Chlamydia trachomatis. The infectious particles usually are the elementary bodies that infect the columnar epithelium. What has caused damage to the tissue is not the organism itself, but the cell-mediated immunity, which is an important part of the immunity in controlling the infections.